Hey guys, I apologize again. My life has been a little hectic. I wanted to get this done. I was going to do it last night, and just as I was sitting down to get it done, I got a phone call that my brother was in a bad accident. So, I'm finally sitting down. I'm going to do the exam review after this. So I should have them both uploaded to YouTube yet tonight. Alright, week 3. Basically, this goes through uncomplicated labor and delivery. Goes through the stages, what to look for, and these come in really handy when you guys are actually doing your labor and delivery or your postpartum sections in the lifespan clinical. I wish we had more options. I know I have a lot of you guys in Boston, which is a hit and miss for labor and delivery. But Julie has the rest of you guys in Gunderson, which is like a crazy, crazy baby station. I know one weekend when I was doing clinicals, I did clinicals on Thursday, Friday, and from Friday night up until Monday morning, they had somewhere like, oh gosh, it was like a crazy number, maybe like 40 births over the weekend. So there's a huge shift in the insurance. So Gunderson is the huge, huge, huge chance to see babies. All right, here we go. Let me just make sure this is, yeah. All right, so there are a few things that affect labor. A big thing is the birth passage. What size is the mom's pelvis? What type of pelvis does she have? And this matters because of how the baby's going to fit through and be able to progress through the birth canal. If the pelvis is small and the baby's big, most likely mom will end up going in for a C-section. The ability of the mom's cervix to dilate and efface. You cannot. Sometimes moms will need help with oxytocin or pitocin to get that cervix to actually efface, thin out, and dilate. And then another critical factor for the birth passage is the vaginal canal and the opening to actually stretch and allow that baby to be expelled, for lack of better words. We will talk about episiotomies, but they are really not done much anymore. It used to be a common thing. Docs would be worried that mom would tear, but now they're saying that the tear actually heals better than a straight cut. And we'll get into all that stuff. So when it comes to the baby, just depends on the size of their head, their fetal attitude, the fetal lie, and the presenting part. Now, these all sound kind of foreign to you guys right now, but we will definitely get into it, and you guys will understand it by the time I'm done. Other critical factors, what presenting part, a cephalic birth is so much easier than a breech birth. Where is the fetal position? Maybe you've heard baby when they're called sunny side up. Generally, you want the baby's back to be towards mom's belly. But if the baby's sunny side up, little things like the baby's nose can get caught on the symphysis pubis and cause more problems to go into for labor. Station depends on how settled the baby is into mom's pelvis. And then physiological forces. This is the frequency, the duration, the intensity of contractions. And sometimes they're going to have frequent, they're going to have intense contractions, but they're not going to be doing anything. They're not going to be helping mom to dilate. Effectiveness of pushing efforts. I've seen babies be born anywhere in 1 or 2 pushes to a mom that pushed for 8 hours. just because she was so worn out. Her labor was so long, and she was tired and didn't have enough oomph to make effective pushing. So her pushing was, or the pushing stage was very, 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 very long. And duration of labor. Psychosocial considerations. Take into consideration if mom is prepared for the birth. I've had births where mom she wasn't sure and she didn't really think she was pregnant. Ended up giving birth at, I think it was 6.5 months. And because she came in for gas pains, that mom was definitely not ready for the birth process. Cultural values, beliefs. I'll kind of get into some of like the Amish births that I was in. Previous experiences, if mom has had a terrible experience with maybe her first child, she's going to be so nervous and tense when it comes to having her second child. Support is a huge thing. Moms can do so much more when they've got an effective support system in place. And their emotional status, are they, maybe they're so anxious that it actually interferes with what their body's trying to get out. All right, so getting into the baby, the fetus. So we'll just go over some of these definitions. Molding is, you can see on here the different parts of the skull. They're not fused in a fetus, so that when they do pass through the birth canal, the head can actually mold, and these bones will go over one another, just so that that baby's head can fit through the vaginal opening. Sutures are basically the spaces in between these bones. And the fontanelles, you can see there is a big one, the anterior fontanelle, and then there's a smaller one, the posterior fontanelle. This is basically just where those bones meet. Like, consider it an intersection and more of like a hole, a soft spot is what it's commonly known as. Fetal attitude. I think there was a quiz question on this, but I did fix it. Fetal attitude is basically the fetal parts in relation to one another. Does not have anything to do with how they are. Sorry, my dog again. It has nothing to do with how they are positioned in mom's stomach. This just has to do with how are they positioned to themselves. So flexion is basically their chin is up and tucked onto their chest. Deflection, basically their head is kind of neutral. It's not extended and it's not flexed. It's just straight. And then extension, you can kind of see on this slide, their neck is extended, and generally these are the facial presentations. Sorry, my dog is attacking me. Hold on.
I'm sorry.
Ari, will you hop up, please? And let her lay down, because she's nuts. Okay, I'm going to try and record this.
Okay,
Keep going.
Can I make your ramen noodles first?
Go.
Oh, sorry.
Sorry, my house is nuts. Fetal lie. Basically, this is the baby's spinal column in comparison to mom's spinal column. If they are a longitudinal lie, basically baby's spine is parallel to mom's. This is when you're going to see them with their head down into the pelvis, and they're either straight up or they're basically straight up and down. If baby has a transverse lie, baby is basically going to be laying sideways in mom's belly. Fetal presentation. This is important even after birth when you're doing the postpartum assessment. Cephalic presentation. This is what we want. We want babies' heads to be down and engaged, and we want that part of the baby to be expelled first. However, sometimes babies are either breech or shoulder presentations. Breech it can be their butt is the presenting, or their it can be a footling breech or a double footling, so that their feet are actually what is presenting. I hope that makes sense. Sorry, Bailey took the dog back upstairs. I don't know, that dog's nuts. Vertex presentation is kind of like flexion. Their head is flexed onto their chest, and the occiput is like the top of their head, is actually the presenting part. This is what the part that we want to be presenting. Is basically that head is a little bit flexed, and the top of their head is what we see when we say mom or the baby's crowning. Sinciput presentation, as you can see on this slide, it's more the top of the head. The head is not flexed, so it's not like the crown of the head. It's just their head is neutral. So basically, what presents is the very top of the head. Brow presentation is exactly as it sounds. Their head is kind of extended, and their eyebrows are what's presenting. So it's not quite a facial presentation, but it's more like their eyebrows are what you're going to see first when baby's starting to come out. And here's the facial presentation. The baby's head is extremely hyperextended, and when mom is fully dilated and pushing, the first thing that you're going to see is the baby's face. So here's kind of some of the breech presentations I was starting to talk about. If a baby's frank breech, this just means that their butt is what is presenting. A footling breech, like I said, could be single or it could be double, so that the legs and the feet are the presenting part. Complete breech, their legs are not tucked up or their feet are not up by their face, so it's not specifically their butt that's the presenting part. They're kind of crisscross applesauce and curled up in a little ball. So the presenting part's going to be their butt and then their legs at the same time. So engagement. When mom starts to go into labor, you've heard of babies dropping. This is kind of what engagement is. It's just when the baby starts to drop, they're kind of getting settled into the pelvis, and you can kind of determine where the baby's at. The ischial spines is considered like the 0 station, and baby is then engaged. When they get to be when they get to the 4+, basically they're out through the pelvis. Kind of goes through more of this. Ischial spines are a 0 station. Alright, fetal position. You guys will hear this anytime you are working with a labor and delivery, a postpartum mom, working with the baby. just because they want to always make sure that they know how the baby came out. So fetal position is basically the presenting part in comparison to mom's pelvis. So you're going to hear if they're right or left-sided. The way I kind of remember this is which side is their back pointing to. I think, let me, I wonder if I've got, yeah, here we go. Up on one of the pages here, you can kind of see that a left occiput anterior, the baby's back is kind of to the left, but more towards mom's belly, and their occiput is what is presenting. Just make sure to go look in the extra material to help you learn. There's a nice picture of mom's, like the example of the mom's pelvis, and then how each baby is positioned. So, they're going to make sure to document the landmark or the presenting part. So you're going to see O for occiput, M for mentum, which is mouth, so that's like a facial presentation. S for sacrum, which is the buttocks, which would be a breech presentation. Or an A for an acromion process, which is a shoulder presentation. So then they're going to want to know how the baby's was positioned. And if you remember that baby's back should be facing mom's belly button. That might, if you guys have questions, please let me know, because I'm trying to figure out how to best explain it. Usually I can draw pictures and show you, and I'm sitting here in my living room trying to show you with my hands, even though you can't see me. So anterior is the way we want them. Their back is facing mom's belly button. Posterior is a little more difficult. Baby's back is on the same side as mom's back. And transverse is just that side lying position. So forces of labor. Primary force is the uterine contractions. These contractions are causing effacement, they're causing dilation, and they're doing the work. Secondary force comes into play when mom starts to push. It's just the abdominal muscles that she has that allows her to push. And know the vocabulary for labor. Frequency. The frequency of contractions. This is what, when you are saying, oh, mom's contractions are 2 minutes apart. Basically, this is from the beginning of one contraction to the beginning of the next contraction. This just kind of tells you how close they are together. Duration is the beginning of one contraction to the end of the same contraction. So you can say contractions are 2 minutes apart, but they are lasting 60 seconds, and their duration is 60 seconds. And intensity. This is the strength of their contraction during the peak of the contraction. They're strong, mild, or moderate. I kind of got that a little bit backwards, don't I? Mild, moderate, or strong. And if you feel your chin, consider that a mild contraction. Feel the tip of your nose, that's a moderate contraction. Now if you feel your forehead, and I'm talking like poking it, poke your forehead, that's considered a strong contraction. That way you do have something to base it on. And moms kind of giggle at you when you're feeling their belly and you got your other hand poking your your chin, your nose, your forehead. You just tell them you're seeing how intense their contractions are. The cause of labor is not exactly understood. Sometimes the progesterone keeps the smooth muscle relaxed, and they kind of say that maybe they don't have as much progesterone release at the start of labor. The estrogen will actually stimulate the contractions, and then connective tissue kind of loosens, allows that cervix to open, thin, dilate, soften. Signs of labor. When I was talking earlier about the baby dropping, this is kind of what I was talking about. It's called lightning. That baby's starting to drop and it's getting settled into the pelvis. You're going to hear mom say, "Oh, I can breathe now," because that baby's no longer pushing up on the diaphragm, and the baby is actually giving mom a little bit more room to breathe. But they are going to complain of more pelvic pressure. They're going to say it feels like the baby's sitting right down there. They may have more leg cramps because of where baby's sitting. Because they went from having their pelvis, and now that the baby's starting to settle in it, their pelvis is actually stretching out, getting ready for delivery. They're going to have more or increased venous stasis, which means they're going to have more edema, more swelling, and they're going to have increased secretions just because that's baby sitting on everything. Towards the end of the pregnancy, they may have some Braxton Hicks contractions. We know that these are not doing anything. They're not dilating the cervix. They're not regular. But the closer mom gets to delivery or to labor, these Braxton Hicks are going to get more uncomfortable. They're still not going to be effective in helping dilate anything, but they're going to be a little bit more uncomfortable. The cervix is going to become softer, which is called ripening. And we talked last week about the mucus plug. And generally it's expelled probably, I don't know, maybe 4 centimeters dilated. But this really means that cervix is opening up, because it is a plug, and once the cervix opens up, there's nothing holding that mucus plug in place anymore. So mom is really dilating, and things are starting to progress. You may have heard of rupture of membranes. It may be that it's a spontaneous rupture of membranes, or the provider might actually strip or poke holes or just get a little hook in there and completely break the bag of waters. Mom may have a sudden burst of energy. They may have a weight loss, a small weight loss, or they may have issues with diarrhea or heartburn, nausea, vomiting. That's why we always try not to have them eat during labor and delivery. One is because they are more apt to get sick during labor, and then if something would happen and they would have to go to C-section. But, yeah. So the first stage of labor, this is where it's called the latent phase. The contractions are now becoming regular. They're increasing in frequency, duration, and intensity. And these are the contractions that are actually starting to do something. Like I talked just a minute ago, they may have a spontaneous rupture of membranes, or the provider might rupture the membranes for the mom. This stage, the latent phase, mom is going to be very happy. Labor is finally starting, and she knows that the baby is going to be here soon. Active phase, moms are going to be a little more anxious. the contractions are going to be a little more intense. Actually, I shouldn't say a little more intense, a lot more intense. And this is the stage where the cervix dilating from 4 to 7 is the range in the active phase. Transition phase is the end of the first stage. Moms may be much more anxious. Contractions are close together and they're lasting a long time. That cervix is dilated from 8 to 10 centimeters during this stage. And mom is going to feel a lot more increased like rectal pressure. And this is generally the stage where they're saying, I gotta push, I gotta push, I gotta push. Just remember that they need to be fully dilated to 10 centimeters before you're encouraging them to push, because I've seen cases if they're dilated to 8 or 9 and they weren't checked and the mom was allowed to start pushing. All they did was cause trauma to that cervix. The cervix became swollen and mom went in for a C-section. So make sure that we're not, they are going to want to have, they're going to have this urge to push, but until we are absolutely positive that they are 10 centimeters, do not have them push. Here's a kind of a nice little chart to compare dilating, or how dilated mom is. A Cheerio is kind of like a 1 centimeter, like a Ritz cracker, 4 centimeters. I always remember 7 centimeters is like the size of a soda can. And then the 10 centimeters is kind of the size of a bagel. And when you are checking to see how far dilated you are, basically you use your pointer finger and your middle finger and you stretch to see how far the cervix is open. So it is kind of a art, and you have to have experience. So having this like right, or having something along these lines when you're checking to see how far mom's dilated is really a good idea until you get very comfortable knowing what exactly the sizes are. So on to the second stage of labor. This is when mom is completely dilated, 10 centimeters dilated, to the birth of the baby. The baby, I don't, disregard the latent and active phases. I'm not exactly sure what that is hanging out on this slide for. The crowning, the baby's head is actually starting to show with each contraction, even if she isn't pushing, which is rare, but that baby's head will start showing, and then when the contraction is done, they may regress a little bit. And then with the next contraction, you'll see the head, and then they may regress a little bit. So, yeah, these are just kind of the movements of labor. You can go in YouTube and kind of look up. You can look up cardinal movements of labor, and you'll kind of get where the baby goes down. They're flexing, they're rotating, they're extending, rotating, and then completely expelled. So the third stage of labor is the delivery of the placenta. After baby's born, the placenta is still there. I mean, baby's still hooked up to the umbilical cord. But that uterus continues to contract and work on getting that placenta to separate from the uterus. Like I said, mom will still continue to contract. Not quite as intense as during labor to get the baby out, but they are still pretty painful. And but now mom has a baby to look at, and she tends to be a little bit. It tends to be a lot easier to deliver this than the baby, obviously. Fourth stage of labor, it can be about up to 4 hours after birth. Generally, this is where you're going to see that shaking chill that they have. There's a lot. They're still kind of trying to figure out what exactly causes it. But they will basically be like they have the chills. Yeah. I'm not going to go over the uterus where it is on this section yet. I've got a picture I want to find. Moms usually generally get, it depends on if they have an IV or if they need to get an IM, but they may get Pitocin, or they will get Pitocin in one form or another. To decrease that bleeding, it helps the uterus to contract and get that the placenta expelled and to clamp off the vessels. So during labor, mom is going to have even higher cardiac output. Their heart rate is going to increase again, and their blood pressure is going to rise during each contraction. It's painful, and mom's body is doing 16 million crazy, awesome things. So, yeah, the heart rate and the blood pressure will increase. Their respiratory system, their demand and their consumption actually increase because of these contractions, and they might hyperventilate. So you'll see some moms are needing oxygen during labor and delivery. And that's basically to keep mom's oxygen up and so that mom can pass on the oxygen to the baby. We talked about mom may be nauseated or actually vomiting during labor and delivery. Their immune system, their white count may go as high as 30,000. Not that they have an infection going on, but they do have a process that is kind of confusing the body. Mom might actually have her blood sugars drop. I have given mom, they shouldn't be eating during labor and delivery, just because, like I said before, the risk for going into a C-section or getting sick. But their blood sugars might actually drop because labor and delivery is a huge energy expenditure. So you can sometimes actually, I used to use honey packets. Mom would be starting to get tired, and all of her sugars were running on empty. And I would just squirt a couple honey packets in at a time, as long as she could stand honey. But it's a high sugar and good source of energy for them. All right. So, what causes the pain during labor? During the first stage, the cervix dilating, it's actually painful. The baby's going to be putting pressure on different structures down below. The lower uterine segment is actually stretching to let that baby out. And during contractions, the uterine muscle cells are actually experiencing hypoxia. Second stage, again, it's the hypoxia of the uterine muscle cells. The vagina and the perineum are stretching and distending, and that's part of the pain too. And then again, it's the pressure on the structures down below. Third stage, like I said, the contractions continue, and the placenta is expelled. So what affects mom's response to pain? Sometimes the childbirth classes may actually have mom prepared so she knows what to expect. Culture. I've done a lot of Amish deliveries, and the Amish women are very stoic. They're actually some of my favorite culture to deliver, but they are taught and they're raised to not show any weakness or emotion, I guess you could say it. And I've seen some crazy labor and deliveries with these guys, and they just take it. I don't want to say take it, but they just don't say a whole lot. If mom is tired or sleep deprived, that is going to affect how they respond to pain. I know in my daily life, if I'm tired or haven't slept in a day, I swear, my feet hurt, my back hurts. Previous experiences, like I talked about before, if mom has had a bad experience with a child or a delivery before, they're going to be nervous, they're going to be tense, and they're going to compare this experience to the last experience. If mom is unfamiliar with the area, maybe she doesn't know the hospital, or maybe she's out of town and goes into labor, or maybe she doesn't know the doc. I know I'm a big rural hospital delivery person, and the doc that you see throughout your pregnancy is generally the doc that delivers. However, in the larger hospitals, you get the doc or the midwife that is on call or as like a hospitalist. So you may have never met the midwife or the doc before, and that does sometimes affect how mom deals with her pain. And if mom is anticipating being uncomfortable, it's going to be a lot worse. How do we determine how babies, their position or their presenting part? We can look. Not always going to be able to just look and not touch. We can palpate. It's called Leopold maneuvers. You kind of feel for the butt, you feel for the head, and you kind of feel around. That's the common one. That's done every time a mom is presenting in labor. Is to use the Leopold maneuver where you're holding the butt and then feeling around for the head, just to determine and make sure that baby is head down and it's not a breech baby. You can also do the vaginal exam and ultrasound. You can actually tell when you go up to check and see if mom's dilated. You can tell what part you have that you're touching just by getting a feel for it, whether you're touching a butt. A butt is definitely going to be a lot softer than a head as a presenting part. So anytime that you're checking mom, you can tell. This is an important part to understand, the fetal heart rate. Even if you are not working in labor and delivery, if your patient is pregnant and something occurs, maybe they got sick and they are in the hospital for IV fluids, you're going to be assessing that fetal heart rate routinely. But what I want to talk about now is the heart rate based on the contractions. So on this, below on this picture here, this is what the strips actually look like if you haven't seen them before. The top one is the fetal heart rate, or the top section is the fetal heart rate, and then the bottom section that says UCs is actually the uterine contractions. So you can see where the contractions are, the little hills. You can see where they start, where they peak, and where they taper out. So the baby's heart rate, we want a little bit of variability. If baby gets squished in a contraction, well, they may have a little bit 5 to 10 point variability, which is good. So then accelerations, you can kind of see here. That heart rate is going up. Oh, I don't know how much this one is. On the third red line, heart rate is actually going up, I don't know, 140 to 170. Baby might be moving around in there a little bit, kind of spinning around and kicking his little legs. So we like to see little accelerations here and there, and then they might, like I said, might be increased a little bit with contractions. Contractions are actually stressful on the baby too. So then we kind of look at D cells. You can see on this picture on here where the D cells are, the onset occurs before the beginning of the contraction. If it's uniform, if it's, you can kind of trace it and their heart rate comes back up. Really not a whole, just watch it. Really no interventions. Just keep an eye on it. Late D cells. This is not a good thing. Basically, mom's blood pressure might be dropping, causing not enough blood flow to the placenta to the baby. So if you look on this picture here, you can see where the contraction starts, and then a couple seconds later, the D cell actually starts. And then you go to the next contraction, the contraction starts, and a couple seconds later, the D cell starts to happen. Variable D cells, you'll see these kind of look, I don't know, when you start reading EKGs, you'll hear top hats are a bad thing. And that's what kind of these look like to me, is the EKG strip top hats, flipped upside down. Variable D cells, not a good idea. Not good. When there are drops like this, it just basically means that baby their head is pushing down on their cord. So they are not getting enough blood flow from the placenta to the baby. And that's what's causing the D cells. So I want to see if I'm really hoping that it's pulling it up when I switch screens here. But this really, this little mnemonic under the extra things to help you learn, the veal chop, really helps me keep it straight. So make sure you're reviewing this. Like a V for variable deceleration, like we just talked about, is a cord compression. Early deceleration, where it's starting to decel before the contraction, think about head compression. An acceleration where baby's moving around, we like that. That's good. But an L for late acceleration, sometimes that could mean that the placenta isn't perfusing enough blood. So really look at this veal chop mnemonic, and it does help keep it straight. Alright, so how can we position mom? We can position mom any way she wants to be, pretty much. Ideas are, they can be sitting on a birthing stool, or they can be sitting in a birthing bed. They can squat. They can, I guess I have sitting on a birthing stool twice. Sorry about that. They can be sitting semi-fowler in the bed. This will help gravity. This will help pull baby down. This can actually help when we are suspecting that there might be problems with the blood flow. It actually decreases the supine hypotension that we talked about last week. And sometimes it can actually make those contractions stronger or more effective. Hands and knees. really, this is kind of a nice position when you got to rotate baby, or if baby is a large baby and has shoulder dystocia, where the shoulder gets kind of caught up in mom's pelvis, then that's not a good day. It really kind of twists that baby so that hopefully they can come out of it without breaking their collarbone. But this is another good position when we needed help with the blood flow between the placenta, the umbilical cord, and the baby. Pharmacological pain management. The pain management in labor is the same thing in pain management with everything else. A patient's pain is what they say it is, and as a provider, if a woman requests pain management during labor, then that is good enough for us. That's all she's got to do, and then we provide the pain relief for her. It just kind of depends on which stage of labor she's in. So our goal is to basically provide the maximum pain relief that we can at that point in labor with the lowest risk for mom and the baby. Let me see where. Oh, yeah. So, like I said, her pain is what she says it is. If she requests pain medications, then she is allowed to have them. And then we just need to determine at what point we want to, or what type of pain control we want to provide at that time. Let me just check. Okay, so in the beginning of labor, 2 to 4 stage, 2 to 4 centimeters dilated, 5 maybe. We really don't want to hit mom with the big guns right away because that's going to leave nothing for once she progresses. So like during the beginning stages of pregnancy, we should try position changes, we should try walking, we should try non-pharmacological approaches like warm rice packs or warm blankets or the tub. A lot of moms find it relaxing to sit in a warm whirlpool tub. So in the beginning, we really want to try and do more of the non-pharm stuff because their contractions are going to get worse, they're going to get more intense, and if we give say we want to give Nubane, and we give it when they are 3 centimeters dilated, we can't give that again for, a few hours. So if they get their Nubane at, say, 3 centimeters dilated, once they get up to 6, they're going to be, oh, I need something. Well, I gave you all I had earlier. Some of the common pain meds that we give during labor are Stadol, Nubane, Demerol, fentanyl. The one that I've seen used the most is actually the Nubane. And if you are administering any of the analgesics, the opioid analgesics, to mom, make sure that you have Narcan on hand. Any of these analgesics cannot be given. Really safe bet is to say anywhere after 8 is not a good idea to start administering opioids. 9 for sure, and definitely not fully dilated because these medications are going to pass into baby and they're going to be too much. I've seen and heard of deliveries where mom wasn't checked before the Nubane was given, and turns out mom was, I don't remember, she was 9 centimeters, and went to 10 really quick because her body relaxed and was allowing the contractions to work, had the baby, and the baby was came out not breathing because they were in an overdose basically by the opioid. So always make sure you have the Narcan on hand. You can give it to the baby. You can give it to mom, either one. But if baby comes out, if they've gotten Nubane too close to delivery, they may need their Narcan. Epidural block, basically it's an anesthesia into the epidural space. It's very common in the U.S. One of the biggest, most important aspects as for us to do is to have mom try and urinate before it's placed. Just before it's placed, we're going to want to make sure we're getting a full set of vital signs, a pain assessment, a good reading of the baby's heart rate, just so that we have a baseline to go through. Once that's done, we're going to want to make sure that they have an 18 gauge straight IV in and bolus mom with 500 or 1,000 mLs of IV fluid. It'll be depending on the provider's preference, but we'll get into why later. So the epidural block might be given, they might be sitting kind of like hunched over their belly, and you can see in the picture here where the epidural actually goes in. It's in that epidural space. They can actually be side-lying too, but I've seen most of them given where mom is kind of hunched over, holding onto her belly, kind of flexing her back. I always say like a cat, like a Halloween cat, and they kind of get the idea. So obviously we are going to monitor vital signs closely. We're going to try and keep mom at a sideline position. We don't want to have her flat on her back. Checking their legs, their sensation every 30 minutes. And we're always going to be monitoring their bladder for distension. A lot of times you will put in a catheter if mom is getting an epidural. And we are always, always, always watching for low blood pressure with epidurals. That's why we give them the bolus, the 500 to the 1,000 ml bolus, before we administer the epidural. Spinal block. This is when mom's got to go in for an emergency C-section. It's immediate onset, and it's on this slide it says ease of administration. It's really not easy, but it is fast and used for emergency. Mom doesn't really require as much medicine. It's a smaller volume that she needs. But disadvantage of a spinal block, mom's blood pressure might drop, heart rate changes in the baby, and they might actually have hypoxia. So this is only used for emergency. A pudendal block, I'll show you the picture, it's a lot easier. They basically find this nerve to go in through the mucous membrane toward the ischial spine, and it's basically the anesthesia is injected next to the pudendal nerve. Generally the last part of the first stage, the second stage where they're pushing the birth, and anytime they need to repair an episiotomy. It's more of a local pain management. Mom can still feel the contractions, and really kind of that when mom is feeling pain from the perineal distension, pain in the vagina, the vulva, the perineum, from the pushing and the stretching, this is what is used. Episiotomy, I don't remember where it is in the material, but you can see on that bottom picture where there's a little slit off to, what is that, mom's right, our left, but it just opens up that vaginal opening a little bit more so that the vaginal opening doesn't tear. Local anesthesia, basically this is an idea of lidocaine into the area. Sometimes it's used for birth, but most times it's injected right into that area for episiotomy and to repair an episiotomy, or actually they can use it to repair when mom tears as well. General anesthesia is generally not used. Mom is unconscious. She needs to be intubated. Bigger risk for vomiting, aspiration. There's more of a risk for blood loss with general anesthesia, and there's a lot more risk that go in for the baby. If they aren't able to get a spinal block in and need to go to an emergency C-section, this is what will happen. When mom goes in for a C-section, any other time, dad is allowed to, or dad or support partner or whoever is in with mom is allowed to sit in the C-section. But once once they have to switch to general anesthesia, their support persons are not allowed in the OR. Version. This is just basically turning the baby. It can be very painful. If the baby is in a breech position, the provider actually flips that baby so that they are now a cephalic presentation. Baby has to be at least, or mom has to be at least 36 weeks or more. They have to have a reactive non-stress test, and baby cannot be engaged in the pelvis. There's no way to turn the baby if they're already engaged. Amniotomy, this is kind of what we talked about, the rupture of membranes. If the provider uses the amnio hook, and either, you can see the amnio hooks down on the bottom in the blue box here, but they can strip them, they can poke holes in the membrane, they can actually go up there with that hook and completely break them. Just kind of depends on what the provider preference is and where mom's at. Amnio infusion, basically this is just the infusion of normal saline or LR into the uterus, because if mom does not have a lot of fluid and baby's starting to get dry, they may add a little bit of fluid to them. Cervical ripening, basically this is the softening and the effacing of the cervix. When mom is induced, this needs to be done as well as the pit. It may be a Cervidil, which is that kind of like a vaginal suppository, or the Cytotec pills. They're both vaginal. Kind of going further into labor induction. This is just basically the provider is actually stimulating the contractions and getting the body to take hold and actually start their contractions. This is generally done if there have been issues with, mom going too long. I know one of my friends when I was younger, she was literally 43.5 weeks pregnant. It was horrible. I felt so bad for her. So different things that we can do to get labor started. Like I said, they can strip the membranes, thin them out. They can actually dilate the cervix with like a catheter. Basically, they insert it up there, get the catheter into the cervix, and then pump up the balloon. Very painful. Most common is the oxytocin or the pitocin infusions. It started at a low dose, and then it's tapered up until the contractions are actually effective in helping mom dilate that cervix. There are a few other complementary methods. Intercourse, breast stimulation. People used to laugh at me. I had a couple come in, and she had been in a couple times with false labor or just starting to get regular, and then they'd pit her out. And then contractions would start again. They were regular, they were strong, and then they'd pit her out. So probably about the third or the fourth time she came in and ended up going home, I pulled them aside and I said, okay, guys, go home, have crazy wild sex, and I will see you later. They didn't believe me. They and she, the mom looked at me and said, "You really want me to do what?" I'm like, "I'm serious. Go home, have wild, crazy sex, and I will see you later." It was about 5 hours, um, and I got a phone call that said, "Yeah, my contractions are about 4 minutes apart. Can I come in and can you check me again?" And sure enough, she had a baby. Herbs kind of start, but you have to be really careful. Do not recommend any herbs to a mom. Um, Leave it up to the herbalist. There's too many aspects that we don't know about that I don't ever suggest herbs for inducing labor. Castor oil enemas. Um, I don't recommend this either. Um, I've been in births where mom was tired of being pregnant. She was at, 40 weeks. Drank a little vial of castor oil, and she was so sick. She was literally pushing and having diarrhea at the same time. Um, and she said, I guess I should have just waited a few more days. But she was so miserable. Um, and you can about imagine how embarrassed she was. I just felt bad for her as well. And acupuncture. And I'm not really sure how to go about the acupuncture. I know there are a few specialists down in my area. And I guess you guys are a lot from Boston, so yeah. Oh, here's the episiotomy slide. Um, Basically, episiotomies, they used to be done a long time ago with every birth. Basically, it's a surgical incision so that the baby, when they come out of the vaginal opening, they don't tear. It could be midline, which is straight. You can see that the midline episiotomy is straight from the vaginal opening straight down towards the anus. Or it is actually off to the side, so it's like a medial lateral um, medial lateral description. Um, Episiotomies, like I said, they used to be done for pretty much every birth, and now they're really not done. They used to say that when the cut was, or now they're saying, I should say, when the cut is straight and like a surgical incision, it doesn't heal as well, and you have more risk for infection and dehiscence and complications. But when the perineum actually tears, the jagged edges, when they're sutured together, actually become stronger, and there's less chance of um, dehiscence and rupturing and opening up and infection. So I'm not really, I haven't seen a whole lot of argument for either, pro episiotomies or anti episiotomies. I think it just kind of depends on the provider. Forceps assisted birth, um, basically, it's just helping mom get the baby out, whether it's a forceps where they go in and they kind of grab baby's head, or the lack of better idea or lack of better explanation. It's basically like a plunger that suction cups to baby's head and helps. As mom pushes, the provider will pull on the vacuum or the forceps and help baby come out. This is a better picture of the vacuum. Um, it's basically um, mom is dilated, baby's crowning. She just doesn't have enough oomph or can't get the baby to progress down the birth out of the birth canal. So the suction cup is placed on the occiput, and as mom is pushing, provider's pulling. can only be used for a short time, 8 to 10 minutes, because it will cause issues. So as you can see here, there's little misshapen cone heads. They're at risk for a cephalohematoma, which we'll get into further down in the course. And they're at risk for bleeding, either intracerebral or retinal. And this it's called a kaput. Will actually it'll disappear within a couple days, but it's not a nice situation. C-section. The baby's born through a uterine incision. It might be transverse, it might be vertical, depending on the reason for the C-section. Generally, the only time that a vertical would be done is in a very, very emergent situation. Nurses assist with all aspects of the C-section. There's a nurse in OR for mom, and then there's a nurse in OR for the baby. So once the baby's delivered, doc will kind of peek the baby over once real quick and then pass the baby off to the nurse. TOLAC or VBAC, I don't know if you guys have heard much about these. The TOLAC is basically a trial of labor after C-section, and a VBAC is the vaginal birth after C-section. There's a huge risk of the uterine rupturing during a TOLAC or a VBAC that most people will just plan. If they have a C-section, their next child, they will just have a planned C-section. I actually was in on my friend's birth. I was working and she delivered. She was one of the other OB nurses with me. But she had, her second child ended up being a C-section. Her third child was actually a breech presentation, and she did a VBAC. She literally, I don't know, I told her she defied all odds with the risk of rupturing the uterus and having a breech baby. But she did deliver naturally. It was a pretty amazing feat. And there's our baby. If you guys have any questions, please get a hold of me. I went through it a little bit fast. This is, and I'm not really even sure if this is showing up, but our labor and delivery and recovery assessment. I will take some time, and I don't know, Julie will go over this, I know for sure, in your clinical, and I'll probably just do the clinical group too. But if you get yourself familiar with this, so that when you do go to labor and delivery or postpartum, you can kind of have an idea of what your worksheets are. It's got the history of mom during prenatal, monitoring their cervix, how far are they dilated, what station are they at, are they effaced. Always make sure you're checking their temperature after their membranes have ruptured, because once their membranes are ruptured, any time that you are checking to see if they're dilated, or anytime you're anywhere near that area, mom's risk for infection goes up and up and up and up. On there, make sure you got the pain scale, or you're assessing their pain, their vital signs. First thing to do when their membranes rupture, make sure you are checking the fetal heart rate. That's number one. Make sure that their membranes didn't rupture and baby didn't drop and are sitting on the cord. Check mom's status. Look at the color, the odor, and the amount of the fluid. Make sure you know what time, and then note any time or any changes in their contractions. So, because usually once their water breaks, their contractions are going to get a lot more intense and it's going to move a lot quickly. or a lot quicker. Make sure that you're looking at fetal heart rates, looking for decels. Monitor their contractions, like I said. Mild is the chin, moderate is the tip of the nose, and strong is forehead. Make sure mom's moving around because that will help with the contractions. And then make sure you're evaluating, making sure anything that you do for mom, go back and see if it helped take the edge off. And then always, like I said, monitor their bladder, especially if they have a epidural. Oh, I think I just hit the wrong button. So I think that is it for week 3 in the uncomplicated labor and delivery. If you guys, like I said, like I always say, if you guys have any questions, please let me know, and I will do my best to answer them for you. If I don't know, I'll find the answer. Yeah, I think that is all I have. Alright, I'm going to stop this one, and I'm going to get on to the exam review.